So today the topic is on the physiology of pregnancy, and specifically we are going to look at the systemic changes which occur in the woman when she's pregnant. Now, these are positive physiological changes which occur to help the mother accommodate and support the fetus throughout pregnancy. And so we are going to pick the various systems and see what occur in them. So starting with the cardiovascular system, during pregnancy, the cardiac output increases by 30 to 50%, and most of this increase occur during the first trimester, with the maximum increase being recorded between the 20th and the 24th week of gestation. And this increase is maintained until the woman delivers. Now, why must the cardiac output increase? It is necessary in order to ensure that there is a constant supply of oxygen and nutrients to the placenta, which supplies the fetus. Now, the increase in the cardiac output is first of all due to an increase in the stroke volume, whereas later in gestation, the increase is due to an increase or a rise in the heart rate. This is because getting to the end of the third trimester, the stroke volume decreases to near the pre-pregnancy state. And so the heart rate increases in order to maintain a constant cardiac output throughout pregnancy. Now, this cardiac output is even much more increased to about 15% in case of twin pregnancy as compared to a singleton. And we also find a significantly larger increase in the left atrial diameter, which is usually consistent with the volume overload. And so the plasma volume is increased by up to 50%, from around 2.5 liters to about 3.75 liters throughout pregnancy. And this is even much more increased in a multiple pregnancy, since there are more than one fetus, and also in a multigravid woman. Now, the stroke volume as well as the heart rate is increased. This is because we've already talked about the cardiac output being increased to about 50%. And the reason is cardiac output is the product of the stroke volume multiplied by the heart rate. And so if the cardiac output is increasing, then it means the products which comes together to give us the cardiac output may also increase. Now, the systemic vascular resistance decreases during pregnancy, and this results in a fall in the atrial blood pressure. Now, this decrease is most likely due to an elevated progesterone levels, which leads to smooth muscle relaxation. Also, we realize that the fall in the systemic vascular resistance rather allows blood to be shunted from other organs to much vital organs in pregnancy, such as the thyroid, the kidneys, and most importantly to the placenta, which supplies oxygen and nutrients to the fetus. Now, when we look at the blood pressure, we realize that there is a decrease in the systolic blood pressure of about 5 to 10 millimeters per mercury, and a decrease in the diastolic pressure of about 10 to 15 millimeters per mercury, which reaches a nadir at week 24. Now, between 24 weeks of gestation and term, the blood pressure slowly returns to pre-pregnancy levels, but it should never exceed them. So these are the changes which occur in the cardiovascular system, and they are necessary to contribute to the optimal development of the fetus, and also to protect the mother from the risk of delivery, such as hemorrhage. Now, still on the cardiovascular system, we realize that as the uterus expands, the diaphragm is pushed up and the heart is displaced upwards by about 4 centimeters and also to the left, as you can see in this image. This is the heart of the non-pregnant woman, and because the diaphragm is being pushed upwards, we realize that the heart is also pushed up and also slightly to the left. We also realize that the anteroposterior as well as the transverse diameter of the chest wall increases, including the entire circumference of the thoracic cage. And so the heart sounds may be different from a non-pregnant state. And this is why you must adjust your stethoscope a little to the left anytime you are assessing the heart sounds of a pregnant woman. Also, in pregnancy, we realize that pregnancy is a high flow, low resistant state. And so the high flow may cause a murmur, which is usually a systolic ejection murmur, which is normal in pregnancy. However, anytime you hear a diastolic murmur, it isn't normal. And so it should require that further investigation should be performed. Preferably, we should undertake an echocardiography to rule out any abnormality in the heart. Now, during pregnancy, because of all these things that we've talked about, we also realize that hypotension and difficulty in breathing is seen in some women. And this is usually when they lie supine or when they lie at their back. And this is due to the fact that there is compression of the aorta and the vena cava by the growing uterus. And because of this, we need to encourage the pregnant women to lie on their left lateral side. Also, during cesarean section, the anesthetist must position the patient in the left lateral tilt to prevent hypotension. Now, in the respiratory system, we are going to look at it in terms of anatomical changes, pulmonary function, ventilation, as well as the changes which occur in the arterial blood gas. And so, anatomically, we realize that because of the hormonal changes which occur in pregnancy, there is mucosal edema of the airway. We also find, hypersecretion and increased mucosal friability. Then we realize that all of these changes are chiefly due to the effect of progesterone on the airway, causing, tissue edema. We also find capillary congestion and hyperplasia of the mucosal glands. And this is why it is recommended that a smaller ET tube be used in case the woman requires general anesthesia for cesarean section. Now, as I just explained, as the uterus expands, the diaphragm is pushed up and the anteroposterior and the transverse diameter of the chest wall increases, including its entire circumference. And so these changes causes a decrease in the pulmonary function, and specifically we are going to have a decrease in the functional residual capacity. Not that alone, we are also going to find a decrease in the expiratory reserve volume as well as a reduction in the residual volumes. Now, because of these, increase in the circumference of the thoracic cage, it allows the vital capacity to remain unchanged, and the total lung capacity, on the other hand, decreases only minimally by term. What about the ventilation in pregnancy? We realize that we are going to find, an increase in the minute ventilation. And this occurs in the beginning of the first, trimester, and it reaches to about 20 to 40% above the baseline by term. Now, the alveolar ventilation reaches, or increases by 50 to 70% during pregnancy. And this increase in ventilation occurs because of the increase in metabolic carbon dioxide production, and also because of the increased respiratory drive due to the high serum progesterone levels. Now we realize that the tidal volume also increases by 30 to 35%, and the respiratory rate either remains relatively constant or it increases slightly. Then also by the 36th to the 38th week of pregnancy, breathing improves in the woman, and this is usually due to lightening. However, we realize that when the presenting part engages or enters into the pelvic brim, it rather presses or compresses on the urinary bladder. And so whilst there is improved breathing around this time, there is also urgency and frequency of maturation around this time. Now, when we look at the arterial blood gas, there is going to be mild hypoxemia, which occur when especially the patient lies in the supine position. We also see that there is going to be what increased oxygen consumption at the beginning of the first trimester, and also this increase in oxygen demand increases by 20 to 33% by term, and this is because of fetal demands as well as increased maternal metabolic processes. There is going to be a decrease in the partial pressure of carbon dioxide to approximately 30 millimeters by the 20th week of gestation, from 40 millimeters during pregnancy. Now, this change leads to an increase in the carbon dioxide gradient between the mother and the fetus, and is likely caused by elevated progesterone level. This is important because there is a gradient that is created to facilitate oxygen delivery to the fetus, as well as the removal of carbon dioxide from the fetus. Then we also realize that during active labor there is hyperventilation as well as tachypnea, which is caused by pain and anxiety, and this may usually result in mild hypocapnia and respiratory alkalosis in the woman. Now, this image is depicting lung volumes in the pregnant state as well as non-pregnant state, and I'm sure you take your time to go through this to understand it much better. Now, with the hematological changes in pregnancy, we realize that even though the plasma volume increases by up to 50%, the WBC count or the WBC volume increases by only 20 to 30%. And so there is a misproportion over here, and this leads to a decrease in the hematocrit level. This causes what we call the dilutional anemia or the physiologic anemia of pregnancy. We also realize that there is an increase in the WBC count during pregnancy to a mean of about 10.5 million per mil, and this is usually caused by the effect of progesterone. Now, during labor, stress may also cause the WBC count to rise to over 20 million per mil. Now, there is also a slight decrease in the concentration of platelet, and this is probably secondary to the increase in the plasma volume, and also sometimes due to peripheral distraction. Now, although in about 7 to 8% of patients the platelet count may be between 100 and 150 million per mil, anytime there is a drop in platelet count below 100 million per mil over a short period of time, it's not normal, and so it should be investigated promptly, and this should be corrected, especially if the woman will require surgical intervention such as cesarean section. There is also elevation in the levels of fibrinogen and factors 7, 8, 9, and 10. However, the increase in coagulation has a protective effect in the sense that it is to help control bleeding in the postpartum period, although it increases the risk of thromboembolic events. And so we say that pregnancy is considered to be a hypercoagulable state with an increase in the number of thromboembolic events such as pulmonary embolism and deep vein thrombosis. The risk of these thromboembolic events is increased, especially in women who undergo cesarean section. Now, the increased rate in thromboembolic events in pregnancy may also be secondary to other elements of the child's triad, and so factors such as increased venous stasis, as well as damage to the vessel endothelium shouldn't be overlooked. Now, the actual clotting and the bleeding times do not change, in pregnancy. Now, in the gastrointestinal system, we realize that the stomach and the intestines are displaced by the growing uterus. As you can see over here, this is the stomach, this being the diaphragm, and see how the liver is pushed up over here. And look at the intestines, how it is compressed. And so the growing uterus pushes almost everything up, the abdomen. And so due to this mechanical and hormonal effects on the gastrointestinal system, all pregnant women are considered as a full stomach or to be in a full stomach state, even if they've not eaten for more than 12 hours. And because of this, it is recommended that a rapid sequence induction should be performed when the woman requires general anesthesia for cesarean section. Now, still on gastrointestinal system, we realize that nausea and vomiting occur in more than 70% of all pregnancies. And this has been termed morning sickness, even though it can occur anytime throughout the day. Now, these symptoms have been attributed to the elevation in estrogen, progesterone, and also increased levels of the human chorionic gonadotropin hormone. Now, they may also be due to hypoglycemia, and if it is due to hypoglycemia, we can treat it with frequent snacking. Now, the nausea and vomiting typically resolves by the 14th to the 16th week of gestation. However, it sometimes continues or even becomes worse off. And this is what we refer to as hyperemesis gravidarum, which is the severe form of nausea and vomiting, and it's associated with weight loss of more than 5% of the pregnancy weight, including ketosis. Now, in pregnancy also, we realize that the stomach has prolonged gastric emptying times, and also the gastroesophageal sphincter has a decrease in its tone. Now, when we put these two together, it leads to gastric reflux in the woman, including, sometimes tylism and also spitting in pregnancy. Then we also find that the large bowels also decreases its motility, and this decrease in motility leads to increased water absorption, which further leads to constipation. And so when we put this together with the pressure of the growing uterus on the pelvic veins, then we may see things like hemorrhoids occurring in pregnancy. And those who already have existing hemorrhoids may get their hemorrhoids getting worse. Then the gallbladder's function decreases. We find that it gets dilated, and its emptying is decreased, and this leads to cholestasis, which may also result in an increasing tendency of gallstone formation in pregnancy. Now we realize that the serum albumin levels falls quite abruptly in early pregnancy. Then also we find that the serum alkaline phosphatase rise progressively and doubles the non-pregnant levels. Then finally we also see an increase in the serum cholesterol levels, which even gets doubled by the end of pregnancy. Now in the renal system, we realize that there is increase in the size of the kidney as well as dilatation of the ureters during pregnancy, and this usually leads to urinary tract infections as well as pyelonephritis in pregnancy. Now this UTI and pyelonephritis may also be due to the fact that progesterone slows down the motility of the ureters, and so urine stays in the tract for so long and it serves as a receptacle for bacterial growth. Hence, the urinary tract infection. We also find that the rising uterus usually tilts to the right, and this causes compression to the right ureters, and this usually leads to hydronephrosis, usually after the second trimester of pregnancy. Now, when we look at the glomerular filtration rate in pregnancy, we realize that it increases by 50% in early pregnancy, and this is maintained until delivery. And as a result of this increase in GFR, the blood urea nitrogen as well as the creatinine levels decrease to about 25%. And this fall in creatinine is also due to hemodilution, which, if you remember, is as a result of the 30 to 50% plasma volume expansion when pregnancy commenced. Hence, anytime we find a serum creatinine level of about 1 milligram per deciliter in a pregnant woman, even though it may be normal in a non-pregnant state, this may reflect renal impairment in pregnancy. And so, due to this increase in glomerular filtration rate, we also sometimes find glucose in urine of the pregnant woman. And even though this may be a sign of gestational diabetes mellitus, it's usually physiologic. And so anytime we find it, we need to rule out other causes of gestational diabetes in the woman. We also have an increase in the renin-angiotensin system, which leads to an increase in the levels of aldosterone. And once we have increased aldosterone, we are going to have increased sodium reabsorption. However, these plasma levels of sodium do not increase because of the simultaneous increase in glomerular filtration rate. However, we are going to have increased water retention in the woman. Bye-bye.